I'm going to go a lot less scientific here, but I guess my objective today is to really, I wanted to step back, like way back in history a little bit, so that we can move forward. And what I mean by that is, my concern is that clinical trials continue to occur based on what's a faulty definition of autism. And I think this is an important time to really rethink how we're conducting trials and what's going into that. So I'm going to really get a sense as to what the issues are. I think it does require a little bit of a return to history. But when we think, what I'd like to do is go through what the current, where I think the current challenges are, but also give some hope for the future in terms of how we can improve. And when we think of the current problems, there are too many really to list, but it's really the ones at the bottom that I want to talk about and then I want to focus on. The fact that we're defining really a clinical syndrome of autism, which has nothing to do with pathophysiology, and it's not a biological definition. So really what this talk boils down to is the fact that if you use a syndromic and behavioral definition and try to apply really a scientific or biological clinical trial approach, those two don't marry very well. You're not going to get much. Sort of like garbage in, garbage out, right? We have a lot of other problems too I list here, like lack of physicians and blah, blah. But that's all for other talks. So, but basically that's, I think, the most important thing that I believe it or not, I think a lot of times when trial design is occurring, this point, which is so basic, is lost on the team, that this is a behavioral-based definition. It's not truly a diagnosis. So when I think of a diagnosis, I think of if you have a strep throat, you go to the doctor, they do a rapid strep test, it's positive or negative, very high sensitivity, you get the antibiotic, we know it works for strep, and you're fixed. Pregnancy test is sort of similar, right? Like, I mean, you're either pregnant or you're not pregnant. It's very black and white, very simple. But what we're doing is we're basing trials on, on a syndromic definition. And when you think about what's in this definition, right? Because this is not scientific at all. It's like, let's think of what we can apply to this. So you have really three things that you've got to have to hit this autism diagnosis by the DSM-4 or 5 criteria. So it's that impairment of social interaction, the impairment of communication, and the restricted patterns of behavior. So if you think of what could fit within that definition, I think we could fit a lot of patients. Whoops, but we could also, I lost the punchline. The point is, we could also fit the medical community into that. I think what's happening is we're having a PowerPoint to Mac issue here. I think that's what happened with the other slides. But basically, the medical community itself really meets all those criteria. Impaired communication, we don't really communicate from one specialist to the other, sometimes from doctor to parent. We have impaired and rigid patterns of behavior. We're still doing trials and treatment the same way we've done for 20 years. I mean, basically, you could fit the entirety of this community into it. But more, like, I guess more seriously regarding clinical trials, like, think of the breadth of patients and the diversity of actual pathophysiology within this extremely broad syndromic approach. So the result, I think, is failed treatment trials, right? So let's think of cancer as a good example. If you had a treatment trial for cancer, let's say I tried to get that funded now. I'm going to go to the NIH, I'm going to say I'm going to do a cancer trial, and I'm going to use medication X to treat cancer. And I don't think I'm going to get that funded, right? It won't work because there are just too many types of cancer, and they're not going to respond to all the same medication, and yet that's exactly what we're doing here. And we have the same problem with slides, but it's a PowerPoint to Mac thing. So, but I have a couple of trials that I show, but like, for example, bumetanide is one that I mentioned. So bumetanide is basically a diuretic, but it enhances GABA. And so when the bumetanide trial occurred, there was a lot of hope for that as being a very helpful treatment approach for autism, and particularly for core symptoms. They used one of the key criteria to enter the trial was having a DSM-5 diagnosis of autism. They also used ADOS as well, but that's not that much better, right? That's really more a behavioral checklist. So none of that's biologically driven. Now, if I have a treatment that's based on GABA, I might purposely choose a population that I know to be hyperexcitable in some way. Or I might think about having a biomarker or an assay to identify that population who's going to be most responsive. More recently, the Ceremin trial. So it's not dead yet because there's I forget the name of the company, but they're going to move forward with another trial, and they're looking still to recruit patients. But the phase 3 trial, they had trouble achieving significance. And again, it was DSM-5 criteria. So again, think, what are the mechanisms of Ceremin, the proposed mechanisms? Mitochondrial is one, and inflammatory is the other. So wouldn't it make sense to put the patients onto the seahorse, see what their mitochondria are doing, maybe do the inflammatory biomarkers, and then use those data to better find significance? Maybe you could do the trial in the broad population, but add the biomarkers to it so that we can make better sense of the data. So now I don't know how many of these slides are going to work, by the way, so this might be like a soft shoe act where I break out into a tap dance. But if that happens, you're all in trouble. But thinking how we got here, so I'm going to go all the way back in history, but I think this is really what it all comes down to. We all know this, but basically we have to think about how societal beliefs and societal patterns have affected science. And let's think about Sigmund Freud and how far-reaching the influence of Freud was. And we really did live in an age of psychology. Freudian psychology dominated so much of the field of psychiatry, but unfortunately spread into neurology, developmental pediatrics, into really the 80s. And, so psychoanalysis had such a far-reaching view, and it's so much so that the focus on early childhood, if you think back to really the 70s, if there were books of Drama of the Gifted Child would be one, which really focused on every little thing that a parent may do wrong to completely screw up your kid for life. And the moms who went through the struggle of having a child with developmental disabilities 50 years ago, their physician was approaching everything from this model, that this was all psychology-based, and it was all what you were doing or what you were not doing that led to this. And that really was where we were. And that was the milieu that Leo Kanner existed within, right? So when you read his original paper, I pulled the original paper, and it's an interesting read. The most telling thing, though, from that first paper was he was at Hopkins, and these were patients collected over about a decade, and he only had I think 11 or something. Now I forget the number. But it's basically what I do in an afternoon, right? But it took him like a decade to collect. And of course, in the paper, and it's written in a style that we don't no longer write medical papers in, but it's almost prosy in the writing. It's almost reading fiction. But they're very detailed descriptions of the families and the dynamics. And this is where the emotionally refrigerated line comes from. He didn't say refrigerator mothers. That was not his line, but he said emotionally refrigerated. And so he described cold mothers and fathers who work too much. I'm sure he never put a hard day in either. But anyway, so so it was really a focus on this dysfunctional mother-child relationship was really the hallmark of how autism was being approached back then, and that's because that was the world we lived in. And if you think of the things that still exist that are based entirely on a behavioral psychological model, and think about the amount of money that goes into ABA, that's like true B.F. Skinner type therapy, right? And in Boston, where I am, there's actually, now this picture is a little bit of a purposely exaggerated version of this, but there is a school in Boston that is using electric shock therapy to regulate self-injury in patients with autism. It's a straight, B.F. Skinner style, psychology-based treatment. Do a few of these kids have, inflammatory bowel disease, headaches, you name it? Probably. It's probably a few. And how do we treat it? We give them electric shocks. This is happening today. This has been very controversial, and obviously, but still occurs. So we're not out of that age of psychology fully, but just to fast forward now to about the 80s, we kind of transitioned from the psychology model to the genetic model. And we're still heavily in this age of genetics now. And in some ways, we're making the same mistake again. So you could say that you have a problem with serotonin transporter, and therefore the mother had an anxiety disorder because of the serotonin transporter. Now the kid has autism from the same thing. And in a way, you're doing exactly what Leo Kanner did, which is to say, this is a anxious mother and who has a child with autism. Or this is a father who's older. This paper about the paternal age doesn't specifically mention that the father worked hard, but it's an older father who child with autism, you're kind of reshaping exactly the same exact argument, but you're doing it through genetics rather than psychology. And so it raises that question about, whoops, if the world, if you're a hammer, it feels like the world's a nail. If you live in an age of genetics, everything is genetic. If you live in an age of psychology, everything's psychological. I don't want to make the same mistake too. I don't want to feel like, we're all at risk. If I study, I don't know, a certain protein or something, I might feel like everything boils down to that protein. But we all have to be conscious of how that societal factors play into it. Oh, and I do have the trials. I apologize, the slides are really tough. These are the trials I mentioned. So, this has been the result of some of the, the end result has been some of these treatment trials which have just not yielded significance. But when you look at the bumetanide phase 3, primary diagnosis of autism based on DSM-5 criteria. I mean, that's how the patients were selected. Now, they specifically mentioned to minimize assessments beyond those strictly necessary, no genetic evaluations or biomarkers were assessed. And so I think that's the failure right there. And I get it, because that's expensive to do, and you run the risk of finding non-significance with biomarkers. But the end result here was a failed trial. Suramin has had similar challenges in terms of gaining significance. There was a trend towards improvement on the lower dose group, but did not achieve significance. Now, if again, the mechanism here is proposed to be partly mitochondrial, partly inflammatory. If we could subdivide these patients, because again, these are based, again, on the DSM-5 criteria, but if you could subdivide that and use some biomarkers to really better assess this population, or to improve, to narrow down the patients that are being studied, I think significance would be a lot easier to achieve. You need more patients that way. That's the downside to doing the biomarker study, and there's the risk too that the biomarkers derail you. An example where it's done right, so I'm going to put Dr. Fry on here. So when Dr. Fry did a folinic acid trial, he included the biomarker. So he looked at whether you had folate receptor alpha autoantibodies. Like, that kind of makes sense, right? It wasn't just based on DSM-5 criteria alone, but there was an actual biomarker, and that helped with the significance. So there are ways to do it the right way. And thinking about how we move forward. So there's a few things that are a little extraneous to the definition, but one thing too is we do have to think a little more broadly about where the actual issue is, because the other part of the psychological outgrowth that we live in is that everything here is based in psychology in the brain still. And the genetics, the feeling in terms of a lot of trials is that the genetics is still based in the brain. So we do have to think about that whole person approach. I mentioned the gut specifically because it's critically important. When I say blood, I'm really talking immune system. I didn't include metabolism here, but that's another key factor. The point is we have to think about the whole person. We have to think more about this as being, whether this is more of a multi-systemic condition. And we have to really think, now that we're in this age of genetics still, but the next logical step is to really link the genetics to environment. And that will happen. I do believe that'll happen with time, but it's going to be a much more difficult thing to think about all the variables going into that. And that's the sort of thing that AI and machine learning, I think, will be very helpful to help reconcile. And so moving forward, moving towards more of a medical model and redefining the condition, thinking about the whole person, thinking about how environment and genetics interact, and then improving definitions so we could actually develop proper trials. So how we could define it, I mean, there are a lot of approaches, a lot of different ways to do it, but you could still use behavioral syndromes as one way to subdivide things. You can use comorbid medical conditions. Like, I could look at a trial of patients with, say, epilepsy and autism, or Crohn's and autism. And I think that's fair game to subdivide. You could think about anatomical approaches. That's a little more challenging because we don't really have good imaging here. But then pathophysiology too, I mean, that gets into a lot of areas. Can we get to a point where we can use things like EEG to subdivide patients, or using their immunologic profile, or using their metabolic profile? Genetics, of course, would be an easy one because we already have a lot of genetic testing. And then other things that have to be considered too, the difference between boys and girls. I think we all innately know that there are key differences. But that's something too we have to consider when developing clinical trials. Regression is really important. Most of these trials, they just say DSM-5 criteria of autism. There aren't trials, I really haven't seen any that really look at just purely a patient population that experienced regression. And that's really a very fundamentally different population, but it's an important one to study. Motor impairment is not usually mentioned as much. I mean, the DSM-5 criteria does not really mention anything to do with motor impairment, but a lot of kids have hypotonia, apraxia, difficulty of motor planning and sequencing. And the easiest thing in the world is a head circumference. It's free to do. It takes 3 seconds, as long as the kid doesn't fight you too much. It yields really important information because we have a subpopulation of kids with large heads. We know from imaging studies that that's increased white matter volume. And so for those kids, we have to worry that there may be like an mTORopathy or challenge with growth regulation. It really tells us a lot about the biology of the kid. And yet it's so easy to do, and it's free, and it's just not utilized. So designing clinical trials. So you could, there are a lot of ways you could design them. The easiest thing and the thing that gets funded today is to do a genetically focused trial. So you have a gene, you have a mechanism for the gene, you might have a biomarker related to that, and then you potentially have a gene-based therapy. And that's what gets funded. That's what people like. The problem is gene-based therapies are really difficult in the brain. There are examples in autism that we'll see. So one example would be in tuberous sclerosis. Everolimus, which is an mTOR inhibitor, has shown that we have seen developmental improvement with that. There is a Dravet study, which is a sodium channelopathy, which is now there are 2 companies exploring genetic-based therapies there. And we'll learn more, but commonly those kids have autism, and we'll learn more as to whether it improves their development and improves some of the core symptoms. You could design a trial based on clinical symptoms, based on biomarkers, and then I think the key that I want to get into is like what we could do with machine learning and how to leverage that. But I'll give you some examples of how can you design trials just based on symptoms. So I think it's a reasonable consideration, but for example, if a child has aggression, they have a lot of fight or flight, that might be a reasonable population to look at beta blockers in. I wouldn't look at beta blockers in all kids. I would really try to subdivide it to those with aggression. Self-injury. If you're looking at something like self-injury, perhaps naltrexone would be, high-dose naltrexone I think would be a very good thing to continue to study. If you have epilepsy and autism, perfect trial for a low glycemic diet or ketogenic diet. That might also be an area too where we want to look at more cannabis trials. Perhaps bumetanide has a role there because of its GABA effect. And things like autism and obesity, which is a really common issue. This is not just purely an issue of patients taking antipsychotics, but because I have many patients with obesity from challenges regulating appetite. We have GLP-1 inhibitors now. Those haven't been studied in autism. I think that's the kind of thing that can be funded. But again, ketogenic diet too would be, I think, a very reasonable option to look at. And in inflammatory bowel disease, we talked about quite a bit yesterday, but trying like TNF-alpha or interleukin blockers or fecal transplant. So the main thing is that based on these clinical symptoms, you can target the therapy along the lines of pathophysiology to yield significance. You could also base trials on biomarkers. So Yale has this coordinated study ongoing to look at biomarkers, and it's using EEG, eye tracking, recordings of behavior and speech. So I think it's going to be really an interesting study to have that biomarker data. What it doesn't include metabolic biomarkers. It doesn't include mitochondrial, for example, biomarkers. It doesn't look at inflammatory ones. But these would still be really useful measures to look at for other trials. And the other thing that's interesting too is that for example, you can subdivide from what they're finding in their EEG work. They're finding that the EEG response to facial recognition appears to be a very useful biomarker, whereas other measures of EEG are less so. So from that, if I need that basic biomarker information if I'm going to figure out which ones I could pull into future trials. And so I think there's a lot more to learn. EEG would be a really good biomarker, but there are so many different signal processing measures that have not been explored yet that we still need to look at. But I really think this is where, and this is kind of the main, focus of what I want to present. I think, in truth, the way to move forward is to really think about utilizing and leveraging machine learning approaches to trial design, and also following the lead from oncology. Really follow what the Pediatric Oncology Group has done by linking much larger patient data sets, developing these like nationally coordinated clinical trials, and linking all the centers together. But to do that and to get those large patient sets, you really do need good, robust machine learning approaches. So what it can do, though, you can do quite a bit. I mean, you can actually start to look at multimodal data. You can look at patient histories, exam findings. You can pull certain words out of the record. You can actually evaluate all the different lab studies and try to find significance in areas where maybe humans would miss. It's even possible to record the patient's speech, record their movement, and incorporate those data sets into better identifying patient groups. And then you can use then the same machine learning approaches to actually design trials, to do not just the trial design, but to do actually like a virtual trial. That's possible to do if you have a large enough EMR data set. And you can predict how a real trial what it will yield. So before actually wasting time and money on setting up a failed trial, let the data set use these EMR systems to instruct you how to design it appropriately. And so there's a few, I lost my, actually it's all, the order, I apologize, the order is all, okay, so I'll go through a few. So for some reason, there's like a lot of slides out. So there are a few different systems to that. So there's a group here at Stanford up the road that has been using this in oncology. So what they're doing is they're doing virtual trials. And they were able to use a very large data set of oncology patients that they could pull from. And from that, they pulled out small cell lung cancer. And then they were able to look at the patient-specific characteristics using word recognition within the electronic medical record. And then look at, they knew whether patients survived or didn't survive. And so then they can, with this system that they've developed, they can actually pull certain variables in or out and ask the question, like, if you designed a trial with these inclusion criteria, what would be the outcome? You change one variable, and then you can see what the predicted outcome would be from that one changed variable. And so you can start to actually change the inclusion criteria. You could change the treatment modalities, and then see what the actual trial outcomes would be without doing an actual thing. And so that can all be done retrospectively, but it requires a huge data set. So they were able to link into, it really was tens of thousands of patients through a de-identified data set that they were using. And that group at Stanford might be a group that we want to talk to about, can we put together something in autism? That would be a worthwhile endeavor. There are also groups, so University of Illinois is also working on using machine learning in clinical trials. And they're doing some approaches that will actually try to predict efficacy of trials. So it will help a lot, I think, in terms of design, do the trial design first using some of these machine learning approaches. And then once you have a really feasible design, then I think that's where you could start to move forward. And so the groups that are working on, the other group too that I thought was really interesting, and this is something Richard could even work on with the seahorses. There's a group from Germany that looked at an epilepsy trial, and what they did is they changed one variable by adding genetic information to it, to see if the trial had been conducted with genetics, what would the result have yielded. So what they did is they went back to the original patient population, did the genetics on 250 patients who were all enrolled in this one drug trial, and then using those genetics figured out what were the key predictors of who was a responder and who wasn't. They did find, now this was epilepsy, so it's different, but they did find that the genetics was highly predictive of who the responders were. But then they also were able to do, because it was a machine learning trial, they were able to look at a large multivariable data set. And so certain things that no one would ever really anticipate were predictive of treatment response, like body mass index, turned out to be a very high predictor. And that's something normally we wouldn't have included. So where I say Richard could use this, for example, if you look at the Sirman trial, they didn't really achieve a significance. But let's say you did like the seahorse data. Let's say you can pull those same samples and they have some blood samples left. You do the seahorse data, and then you see what the significance is based on mitochondrial functioning. That would be an example of how you could just like, without doing the full trial again, there's potential to salvage some of these prior failed trials. And so I think all of these groups are really interesting. I think the one that is probably the most interesting, and I'll be happy to share the research, is this group at Stanford, though, that's doing a truly virtual, has a model to do completely virtual trial design. And what they require is a large data set. So let's say you knew someone who had an EMR system, let's call it Charm Health, for example, and you had a lot of patients fed into that, and you can collect all that data into one system, then you could actually just run the trials right from that. So that's, I apologize, the slides are a bit of a mess. I had some extra credit slides, which were just really going through a neurologist approach to this, but that's really, that's really where I think we have to go. We have to really rethink our entire approach. The definition has to change, the use of biomarkers has to change, and then the trial design has got to start to leverage machine learning, because we're looking at a very complex, multivariable, concern here, and there's no way to do it with the existing trial design that we're using. So thanks.
Thank you.